Okay. The great Zen master Dogen once famously said, "Life and death are of supreme importance. Time swiftly passes by and opportunity is lost. Each of us should strive to awaken. Take heed and do not squander your life." Now, occasionally a time or a situation comes in our life, and when we accomplish this sensation where we feel that we have really achieved the purpose of our life, and probably if this is the last moment of our life, we have done it. Now, for me, conducting and holding this session is one of those moments, and I hope that it would be the same for the ones who will experience this session through recordings and through live session today. And the reason why I feel this way is because it's one of those rare opportunities which has come to us through this session, where we will be discussing nitty-gritties of a surgeon's mind, which are something through Cartesian split around almost 400 or 500 years back, when the body and mind was split, and the whole emphasis on body being a separate aspect just creeped into our psyche, creeped into our actions, and we never really introspect the reasons behind our actions. At various aspects in the book, Dr. Marsh says that to operate the skill is a very easier part. Anybody can do that. The most difficult part is the decision making. And that is the fundamental take-home lesson which I think our attendees will have today, that how to take good decisions. And this is what Dr. Marsh has shared with us through this book, a beautiful book, which after reading this book, all of us feel transformed, changed as surgeons. And I wish, I'm extremely grateful to my guests today who have agreed to be part of this session to discuss and share this book with me and their experience and insights on what they have understood about the book. I also wish to welcome and thank the attendees who have taken their time off on this day of Yugadi and a holiday, and Srini, who is sitting in a conference, taking their time off to share this, share their time with us, and let's embark on the journey. Without further ado, I would like to now invite Dr. Krishnamurti Banantaya and Dr. Srinivas Ramchandra to take over. The whole session will go in a way, because conducting a book review is difficult generally, and we are trying to do it in our own way. We are trying to experiment. It's very experimental. So what we have decided to do this time is that we will be dividing there are several chapters. Not all the chapters will be discussed. The points from some of the chapters are highlighted, will be discussed. And if it generates any interest, attendees are requested to go back to the book as per their liking. Having said that, the details of the book are available on the net for everyone, but one of the most important review which we have seen on the net is Truth at a Very Unlikely Place, a brutal truth which has been spoken through at a very unlikely place. So that is what we are trying to accomplish through this session also. Speak the truth, speak the software of a surgical surgeon, a software which is our mind, which is what we are trying to dwell into. How do we think, and how do we act, and how do we operate, and what are the factors which work against us, what are the factors which help us in taking good decisions. The floor is all yours, Dr. Krishnamurti and Dr. Srinivasan. Please introduce yourselves, and then we shall proceed.
Srini, you first.
No, the distinguished and the gentleman here first. So go ahead, Dr. Banantaya.
Thanks, Srini. So I'm Krishnamurti. I'm a maxillofacial surgeon. I live in Bangalore. I work in Bangalore. and I have successfully overcome this pandemic till now. And reading is my passion. Taranjit introduced me to this author. I'm grateful to her for this and among other things. It's a lovely read, and I hope we have a nice discussion discussing about various issues that he has raised and trying to correlate that to our own experiences. Thank you.
Thank you, Taranjit, and thank you, Kita. This is a privilege as well as a sort of a personal journey. You know, I remember carrying a bicycle which had a flat tire on the same paths which Henry Marsh has traveled between St. George's Hospital and Wandsworth Common. So my name is Srini, and Srini Chandra. I live in Seattle. I work in Portland, and I'm a maxillofacial surgeon and a student of life. And as you said, I have a small cemetery of mistakes too myself. So I will look forward to a wonderful discussion between he inspired me. Kita, when I was in dental school, was a medical school character. And when he was doing medicine, I was wondering, what is this guy doing? And the more and more I've learned about his life and his journey, and Taranjit and I have shared a lot of consequences of coincidences together. So I would love to see what this book is about, and we will talk about that.
Thank you, gentlemen. Let's start. Okay, so in the first chapter, Pineocytoma, Mr. Marsh talks all about balance, and he talks about role of self-doubt. He talks about a lot of things. But there's one thing that he talks about is impact of past failures on the current surgery at hand, the feelings of dread, and how does one deal with it. When we have had a past failure of a similar surgery, and then we are doing it in our present situation, and all the ghosts of the past come and haunt us. How do we deal with these? Dr. Kita?
Yeah, this is something that most of us have experienced if we have done enough surgeries. One of the ways is to not continue doing it. You end up sometimes, as you know, in a surgical career, in the terms of your operating skills or the variety of things that you do, it's more like a pyramid. You start off looking at assisting a whole range of things, and then start doing some of them, maybe under supervision if you're lucky, maybe without if you're not so lucky, and then end up doing only a few things repetitively, what we call as specialization or super specialization. And one of the reasons why it becomes a pyramid like that is past failures, I feel, because I assume that most of our attendees here are maxillofacial surgeons. So if I assume that, I can give an example. For example, if I have repeatedly failed trying to do cancer surgery, either failures that occurred on the table or later on because the outcomes were not so good enough, after a while, if I'm a sensible guy, I'm going to give it up. However, what he's referring to here is a different thing. This is a kind of situation where you are continuing to do the same stuff regularly, and then if you had a couple of bad failures, you sometimes spend your time, sleeplessly waiting for the morning to come and for you to be in the theater, tossing and turning in your bed and hoping that everything goes on well, because sometimes it's difficult to know why these failures occurred, and therefore there is a significant element of unpredictability to this. Yeah.
Srini, what are your thoughts on this?
And as Kita said, we need to learn from our failures as well as our successes. So if everything is like a bell curve, our experiences in life is like a bell curve, as Kita rightly said, you want to know the outliers, that is the corners or either corners of the bell curve. What I did do correct on a successful story, and what I did do wrong. And most of my journeys are my attributions to learning or introspection, if you say it in one word, is to see what caused the failure and what was the cause of success. So the middle part of it, the majority of the bell curve, you'll go through life without even remembering them. So in the bell curve, you want to explore if there is a failure. As Kita rightly said, reach out to another person who's done this or why you're not succeeding in this part. So as Henry Marsh quotes this book, Complications Are Another Thing, why don't you get a coach? So the coach, every major spectator sport or major consequential sport or action has a coach. So if I reach out for cleft surgery with Kita or cancer surgery to you or trauma surgery to you, is you're trying to succeed by hiring a coach or talking to a coach about your failures. So that's one part of the bell curve. But at the same time, every journal you open, every textbook you open, it is about the successes on the other side of the bell curve. That is the small bet of it. So you learn from masters who have done them, successfully. So this is my concept about talking about this. But Henry Marsh very well alludes to this in another book, which he gets inspired from, I think, Canaban's. Again, I'll quote this multiple times. It's a bias. If your 2 operations have gone terribly wrong, the third you're stressed, anxiety prone, and you come to the operating room very, very bundled up in a piece of, a high flowing nerves. But same thing, success gives you arrogance. So somehow you want to exist in the middle of the bell curve, but learn from the corners of the bell curve.
So that's what he's trying to talk at every step in this chapter, particularly the balance, the balance between extreme anxiety, at the same time being confident that you can still proceed. I think that comes only with time. And I also understand that one failure should not deter you from doing the procedure, right? It's introspection, and then discussing, as you both said, that discussing with your mentors. I think, Kita, don't you think a role of mentors also comes here into play? If you have a mentor with whom you can discuss your failures very honestly, who can take you through the steps, what would you suggest? What would you say?
I do agree with that. Sometimes if you're doing the same mistake, you may not realize where or what is the mistake. And if there's someone else either watching you or listens to your narration, might easily pick it up and say, hey, this is where you might be going wrong. It might be very simple thing. It might be your depth perception. It might be the way you're suturing your flap. And then it becomes an easy job, that you tell, the mentor tells you that this is where you're going wrong, and it's very easy to correct. But that if that is not the case, either you do not have an opportunity to discuss this with somebody, or it's not obvious. The problem is not obvious. There are times, believe me, I can give you an example of a very simple thing. A colleague of mine who had a few failures doing a dorsally based tongue flap, and I was standing the next time and I saw this happen, and throughout the procedure I did not see anything that went wrong, to point out and say, oh, this is where you're having a problem. If you change this, it could change. I couldn't find something very obvious. Everything looked proper to me, and that flap failed as well. And for a while, for a number of years, this friend of mine stopped doing this, because when you can't figure out what the problem is, then you don't want to have a heap of failures of the same kind. Then you're just making a mistake. So he started using other things instead of the tongue flap. But then if your brain is plastic enough, or you're foolhardy, you can go back and try that, and you could still succeed. So these are fascinating things. The only problem is at the other end of your fascination is a living human being whose flesh and blood you're cutting. That's the only worry, you see. If it was,
that's a big worry, and that is the reason we are having this session, because
if you were carving a vegetable and you're not getting your duck, you can keep bringing that vegetable again and again and carve it, you know. But here you are not allowed, or you don't have the luxury of affording these failures. Yeah, that's where the problem comes in.
What I feel is that about the honesty bit, the Henry Marsh is honest about, I think it's very important to honestly admit that there's a failure. So many times as people and as surgeons, we tend to push our failures to somebody else, like something went wrong in the team, or, you know, somebody did this or something that, and it was not my mistake. You know, so many times we refuse to even accept the responsibility for the failure. I think if we have not done that, how do we learn from our failures? Don't you think so? That's an important aspect of it. At the same time, there are surgeons now, when we listen to these surgeons giving glamorous lectures in the conferences, they are always talking only about their successes. They are not talking about their failures as much. But and that inspires youngsters to go ahead and take up the profession, take up those kind of surgeries, and they're not well equipped about the failure part of it. And then they feel that they can go on the YouTube and see the surgery, whereas in that also the complicated steps are all skipped. So what would you say about that, Srini?
You know, two things come to mind, and I will relate that to Henry Marsh too. As Kita said, and you're alluding to Henry Marsh. Henry Marsh does describe about failures, but he still comes across as a little pompous throughout his book and throughout his demeanor. But he doesn't blame anybody, but he blames circumstances and triggers and other things. But saying that, he never mentions a mentor whom he is looked up to, or describes anywhere in the book of talking about a mentor. Yeah. To seek a mentor, or for instance, to know what mistake you committed, you need total honesty with yourself. And Henry Marsh talks about self-deceit. Self-deceit while you're doing it for the first time, self-deceit when you're doing it as a trainee, self-deceit to boost your confidence is good, so that you can attempt bigger things. Because there are some flaps which I've done only once during my training, and then I go out and do multiple ones, very well afterwards. So I need to have some amount of self-deceit saying, oh, I can do well with this. So coming back to the two words, which I would say is luck and honest error identification. So your successes could be because of luck, and at the same time, it could be an honest error when you have a mistake. So you need to classify these two, luck and self or honest errors.
It also brings element of humility in our attitude.
Yeah. Mm-hmm. Yeah. Honestly, if I don't know what my mistake I'm doing, I cannot seek help. Yes. And humility is an utmost importance in every surgical or medical trainee or any profession, I would say.
Wonderful. So there's another aspect which he talks about in this particular chapter. There are two things, in fact. One is the informed consent, the aspect of informed consent. And the other is night before rounds. Now, a lot of our surgeons, we, especially the ones who are in training institutes, we don't even go for night before rounds. It's done by our trainees and, people who are just learning to. Whereas that's one part of it. And they're also the ones who are handling informed consent for us. And we think that it's just part of the routine. We don't take it very seriously. It's like a formality that has to be a step that has to be finished before we reach the OR. But Henry Marsh doesn't think it like that. He has played a quite emphasis on these two steps as well. Would you please share with me your thoughts on the same? Srini?
Thank you, Tanjit. So informed consent by itself is another topic for many, many hours. And one of my in this book, or at least I'll tell you the relationship between what I experience then to what Henry Marsh's informed consent is. Informed consent as a peculiar thing, even though Hippocrates said in 490 or 460, whichever place you go, it's BC 490, 460, there's a huge difference of a few years there. Informed consent did not start off very well, or even to date is not used really very well. Informed consent, especially in the area where I live, is still undergoing a lot of turmoil, because informed consent for research, informed consent for procedures, implied consent, and people who cannot consent, people who consent under duress, people whose consent has been eloquently neglected for centuries, is a huge thing. So the first bombshell, or the exact paper which reference to the informed consent, even in research and regular life, comes from around 1930s to 1940s. Even though American Medical Association had made informed consent as a peculiar thing or absolutely necessary thing in 1850s, till 1990s, 1996, 1997, we still kept experimenting on people who could not, or who were coerced into giving consent. So Henry Marsh uses informed consent as a problem many a time. Like, I agreed, it's wonderful to go to the hospital the night before to see the patient, but there was another reason for that, because he didn't want to be stressed, and he didn't want the patient to see him stressed in the morning of surgery. And I used to go to the hospital the night after surgery, first 48 to 72 hours, I would round 4 different times before going to bed. And that was taught to me by a couple of my good trainee, mentors at some point of time. And not everybody sees that as necessary. Seeing a flap before you go to bed, or seeing a patient is critical in the ICU only before going to bed, is essential. Anyway, coming back to informed consent, minorities or people who say, slumwala experiments have been done throughout centuries. So nobody gave informed consent. The biggest migration or forced migration in this world is the, the slavery, the bad thing about slavery. None of the people who were brought as bonded human labor had informed consent choices, but surgeries were performed throughout the hundreds of years, at least in America. And as late as 1996, Ivy League schools like Johns Hopkins, University of Pennsylvania, you name a school in America, has been involved in performing surgeries or performing procedures without informed consent. I can elaborate on those multiple different times, but if you ever get across a book called The Bleacher's Bombshell, that is the sore thing about a Harvard anesthesiologist who informed the world about the egregious procedures other surgeons were doing, without telling that he was doing experiments on medical students without informed consent on psychotherapy and LSD, I think. So wherever the consent comes from, informed consent, the popular consent about complications from Harvard, the chief of anesthesiology of Harvard was the one who brought the controversy of informed consent initially, and he didn't tell about his own informed aggressions or informed consent. So I'll let Kita and you chime in to say what else you want to talk about informed consent.
Kita, don't you think informed consent is more about medical legal implications? We are just worried that, tomorrow if there's any situation, the documentation has to be appropriate, and a little less about how patient is feeling about it?
I don't think it is less important. Obviously the medical legal part is important. We have to make sure that tomorrow, if there is any questions raised, everything is proper and it's part of the rules, etc. And therefore, informed is what is we are debating here. Consent is always taken. It's the debatable part is what informed means. you can't really standardize it. This is my experience of 30 odd years. Dealing with patients who come from very wide variety of backgrounds, both socially, economically, in terms of educational levels, etc. And what you need to inform a given patient or a parent, in most of my cases, varies. Sometimes they are so dumbstruck that they don't, even today in the Indian scenario, that they don't ask anything. They don't want to know anything more than the fact that you're going to do it and you're going to set everything all right, even if you know that you can't set everything all right in a number of situations, like in my cases, but they think that is going to happen. It's implicit. Whereas on the other end of the spectrum, today we have people who would have written down the questions and they ask them one by one. They quote you from this stud paper and, oh, I was speaking to the other cleft surgeon. He said this breakdown will happen if there is vascular necrosis of the edge. So you get people. So therefore, what I tend to do is I try to satisfy the needs of the parents or the patients. What that means is, for every different person, the consent is taken, but the information is variable. This is the practical reality. And I don't do it in the wards these days. I'm getting old. I stay in Bangalore city, where it takes 5 minutes to travel a kilometer, and you have to manage your life in such a way that you're in the right place at the right time. So most of the talking that I do is like a pre-operative clinic. It could happen on the day of admission or a few days before, when the date for surgery is given, but invariably get to speak to most of them, if not everybody. And this is what happens. There are people who will ask you, who do you think is the best person to do this? And then that also is part of information. If I know somebody next door who I know or I think is much better than me in doing that thing, I will have to tell them that, because information is not just about how the procedure is going to be, how long it will take, what may be the problems, how you will recover. But today people ask you these questions. Doctor, they are ready to get operated by you. They'll say, doctor, can you recommend who is the best in this area to do this rhinoplasty? So, you can be put in a tight spot. So it's a very interesting thing. I think it's important. It depends on what is in the minds of the receiver, the patient or the parent, rather than giving things, because I have seen that even in places where it's codified a lot, it's still difficult. Do you tell everybody that there is a 0.04% of chance of a death due to a general anesthesia? Do you tell patients that you will get numbness from a BSSO? So these are things that you will have to decide, and practices vary. But in general, I think we need to speak to our patients at some point of time, be it previous day night or previous day morning or a week before, where they make up their minds whether to. So I think it is more important to do this while you're trying to schedule the surgery rather than the previous night, because by the time they're already admitted, nobody's going to walk out afterwards. It's all very well to say, yeah, I gave an informed consent, but you're already admitted, your workup is done, you walk in like how Henry Marsh does, and by that time, virtually nobody will really walk out of that surgery saying, this information given to me makes me think that I should not go ahead with it. So yeah, from that point of view, it's more medical legal. But the bottom line should be to give reassurance, I feel. I don't know, depends on what kind of patients you're dealing. If you're dealing with somebody with a bad tumor in the brain, which is going to give you a life of 6 months, what you will inform compared to me talking to a parent of a 3-month-old whose cleft palate I'm going to repair will be different. The optimism or pessimism or whatever that comes out of this information will vary based on the circumstance. So it is a very, like Srini says, a very interesting thing. I don't know much about the law, and unfortunately, Georgie is not there today, I think.
He had a dinner appointment. That is the reason why he said he would be.
Okay.
It was
Okay.
doubtful. But
Right.
having said that, don't you think when we are informing the patient about the situation and the procedure and all that, how
Yeah.
patient has
That-
understood? You know, how do we know that what we are trying to inform patient
you
has
won't-
understood? You know,
You
yeah,
won't.
we
You won't know.
Yeah.
I used to work as an SHO in England 30 odd years ago, and I'll go around telling to this 18-year-old kid that, oh, you'll have swelling, you'll have paresthesia, you'll have this. They'll say, yay, yay. And you don't know what is this yay, you know. And then next week when they have a numbness, they say, hey, it's numb here. What do you do to me, you know? So many times it doesn't register, honestly.
Yeah. It doesn't unless it really happens, and that's when the
that's why I said if the person has questions to ask about it, it becomes where they have whatever the doubts, you know, depending upon the level of their understanding, that conversation is always more useful than a codified, structured, but you need to do it.
And I think this is how, through all these points, he tries to highlight the role of balancing the anxiety versus confidence, balancing how much information you are supposed to give and how you give, towards not really withholding, but not trying to create the situation of fear in patient's mind. And that
I agree with that. I agree with that fully. Yeah, that finding that balance is an art by itself, and it will take many years before you know.
I think communication, we all, like Nietzsche one very famously said, your language dictates consciousness. And the language that we use, you know, the words which we choose to express our opinions, or even the information that we want to pass, the language which we use, the gestures which we use, I think could also play a role in how our patients are going to perceive this, and then accordingly make a right decision for themselves. Because there's so many times they don't choose the right procedure, you know. They just don't choose it, even if that is the procedure which would really give them a hope of life or something. They would still not choose it because they're so scared because of the way you have expressed the situation to them.
I agree.
Yeah, don't you think so?
Yeah.
Okay.
You know, the couple of points, Taranjit, if I could add, is the person doing the surgery, say for instance, Henry Marsh who's doing surgery, or anybody doing the surgery should obtain consent. And the consent should be obtained in such a fashion, as Kita and you both are saying, where the patient understands what you're trying to convey, body language or the communication skill, the verbal language, other things. And you need to have a situation where the patient can comfortably, without under duress, which is pain or sedation or hierarchy or, lack of what you call social status, all this play into consent. So you need to empower the patient. This is the only place which you can empower a patient. And, you know, they are the vulnerable most at the point of when they have pain, tumor, or anything. So you need to empower the patient. So informed consent of blank checks are not applicable. They should not be done. Like, you know, informed consent saying all the related procedures should never be an associated thing. You know, you should try at least breaking down into the, not every minutiae part of it, but at least the major components of the surgery would have to be explained. Nowadays, in most private offices, if you go to a bariatric surgery or somewhere, they would show you a video of how the bariatric surgery and the techniques of bariatric surgery are. You see the video even before you come to the surgery, and then agree to or ask questions or the type of surgery you want. So there are various methods where you can really convey the messages. You can have a standard video, you can have an illustrative video, you can have somebody who has a similar experience talk to them. So all these are process of informed consenting.
And that's that's how we can empower our patients. And that's a beautiful thing that you said, empowering our patients with the knowledge, because not all of them, like Kita said, would have Googled their information and everything. So the ones who haven't, by providing right information in the form of videos and experience from the past patients, we are actually empowering our patients to take the right decision for themselves. And that's wonderful. That's really wonderful. Let's move on to the next chapter. on aneurysm, this particular chapter where he, where he talks about, through this chapter, he tries to talk about self-importance that creeps in us due to our profession, something in lines of a God complex. It not just affects our core relationships, it in turn can affect our work, our thoughts at the same time. So my question is, which was actually Kita's question in the previous session, do surgeons suffer from God complex? Do we suffer from God complex as we grow, with experience? Yeah, Kita. Please, anyone. Yeah.
Srini, come on. Are you God?
No, I can never be. I do not understand what that concept is. But I like this way he talks about. Actually, the chapter 6 is almost similar in his feelings compared to chapter 2. Engor enemy, or however you say it, the perception you have just before you die. Some people say during an MI, when you're about to die, then God appeared in front of me, or anything like that, things like that. So the patient experiences that, while I have no such complex. I'll tell you, I want to be as grounded, as humble, as honest. Every association I try make is towards that, because at least cancer teaches me to be very honest and humble, that you are not God. The COVID wouldn't have happened if there was God or such things like that. But anyway,
yeah. So, Srini, taking off from where you left, I've seen a lot of people who play God. I have. I'm an atheist, so I can't play God, therefore. But I have seen this. What do you really mean by that? What you really mean by that is, Saranjit, my son is doing something behind me, so that's why video is on.
No problem. Okay.
He was just taking some clothes. No problem. So what it means is that I know what is right for my patient. That's what playing God means. You know, oh, who is he? I am the guy who was trained for 18 years. I am the guy who wills this. But this can be a conceit of the worst order, simply because it will detach you from reality. I've seen it in even young surgeons as well. It's not just necessarily old people. Maybe as they get older, they might get mature and stop thinking like that. This is, I don't know how common it is, but it is there. And there is no way you can have that kind of an idea. I see them as customers, and I see myself as a service provider, and that's it. There are some differences between other service providers and us, but end of the day, you have to believe that your customer is right. Then you won't play God. Simple as that.
Srini, do you agree with that?
I agree with that, because every profession, every human being has a time when they feel like God, I suppose, But ultimately, I summarize this God complex into two personal things, two words which always come to say, like, for a patient, I have empathy, and towards me, I have self-awareness. So at no point I can be God, right? All I'm expressing through this complex is empathy by saying that I have a resource which I can help you with my technical skills or my knowledge or previous experiences. At the same time, I'm self-aware. If I'm doing a cancer resection, I cannot see where the oncological lineage of cells or the cluster of cells have gone. I do not know the fracture is going to heal. What if it doesn't heal? So I'm self-aware of that. At no point at any type of surgery which I undertake, even in a neurosurgeon, a glioblastoma resection or meningioma resection, without having that empathy and self-awareness, as Daniel Goleman again says, emotional intelligence, if you conquer or wonder about those two words, I think God complex would recess by itself.
Before we move on, don't you think God complex in so many ways is transferred to us through our patients themselves? Because, so many times in order to hide their own anxiety and fears, they come and tell us that, oh, you're like God, you're like God. And somewhere down the line, we actually start believing that, yeah, especially if our surgeries have been successful, and we actually start believing that maybe I have that magic in my hands, have magic, and I can, do that. Don't you think that happens?
It happens with the people who rule our country. We are supposed to be a democracy where we elect our representatives, right? But once they are elected, they become our rulers.
Yeah.
Ruler as referring to the Raja or whatever, and Raja becomes the king. Yeah, it's in the culture, but yes. It's quite easy to, you see it all over the place, not just with surgeons, like I said, yeah. Ooh.
Hey, Taranjeet.
Hi.
Can I just add something? Hi.
Yes,
hey, everybody. This is such an interesting,
yeah.
such an interesting conversation, but I'm just trying to play a devil's advocate, and I thought about it. Why is it so bad to have a God complex? Why is it considered superior? God never, all of us have learned this way. I mean, atheist or not an atheist, we know that God never does anything wrong, right? I think it gives us a sense of responsibility that we always want to do right, because, oh, maybe I have that kind of a privilege which has been provided that we can serve and provide this care. So I'm not going to do anything wrong. I'm going to do everything right, which is right for the patient. Could God complex be seen positively rather than a superiority complex? Could God complex be seen as a responsibility rather than a superiority complex? Makes me wonder, it's I think as we go through our residency, in United States, as we go through a residency, I think the younger days we do get compelled to have a feeling of God complex. And as we kind of grow in our career, it kind of humbles us down further. But I don't know what to think about God complex. Is it good, bad? Is it a superiority complex or just a responsibility? What do you guys think about it?
Yeah, I think it's how you see God. If you see God as omnipotent, omniscient, omnipresent, then it's a bad thing to have. But if you think God as a human being who can make errors and, on his bad days produce a bilateral cleft lip or a midline dysplasia or a TOF, then that God is not is okay because he's human like us. So it just depends on how you see God. But if, like I said, if you think God is potent, omniscient, omnipresent, then that I think is a bit dangerous role to play. This is just an opinion. Right. Yeah.
Each one's perspective, I guess. Sure. Yeah.
Srini, what do you think about that? I think it's a very interesting point Aarti put in. The different perspective. Why not?
So, I mean, this book made me think. I was reading it in my flight on my way back, and I was like, it's interesting. And then I kind of closed my eyes and thought about it. I'm like, how bad is that? It's kind of I don't know, both the ways, I guess. I agree with all the points. And then
but it just made me thought. Aarti, but we do know deep inside that we are humans and we are fallible, right?
Absolutely.
Right? So having a God complex, even for a moment, and thinking that, we know something, like Srini was saying, we know better than the patient, what is good for him or her. How do we know what are patients' expectations from their procedure or recovery, XYZ? So God complex takes away all those doubts from us. And self-doubt is something that, is something that we are trying to encourage, in fact. What do you think, Srini?
And
Aarti, I will entertain you with another thought. Okay. No deed is done as a single person. It takes a village to raise anybody, right? Henry Marsh did not succeed by himself. Atkinson Marley Hospital are the trainees, are the mentors, and everybody. So if I have to go to war, it is the soldiers I require, not the officers. It's the officers or the generals who are the God complex people, not the soldiers. So every surgery I do is a set of team. The team comprises of my wonderful nurses, my scrub technicians giving me the perfect instruments, and the medical oncologists, or everybody. It's a team. The moment I forget the team, I start feeling self-important. And just because I am doing the technical aspect of it doesn't tell me that the radiology procedure or the pre-embolization of a tumor which has been done is as skilled as what I do. So I don't know, team player,
Yeah.
I cannot be a God complex person. Second thing, majority of the things in this world, say for instance, when Michael DeBakey, the cardiothoracic surgeon, the hundreds and thousands of thymectomies or unnecessary procedures which were done with great glory and glamour, what happened to the God complex? When history treats Michael DeBakey, it's not the right way. So we need to be humble, because tomorrow what I'm doing may not be the correct thing. Cutting out a tumor 1 centimeter away from where the margins are, 100 years from now, people will laugh at me. So I don't know. So this is the thought. I would leave that to you to understand. I cannot be God.
Right.
Does that convince
Oh,
you?
I'm not even. Oh no, so my question is not about being God at all. Absolutely not. I'm not saying I'm right, and I'm totally a team player. Totally get it. My only question is, why is God complex so narrowed down? I mean, I think I agree with Dr. Kitta about it too, because it's the way we see things. For me, I'm not saying that I have that supremacy complex of like, oh yeah, I can treat this, so I'm a God. No, absolutely not. For me, I've never seen. I know that for anything, God can never do anything wrong, right? Being philosophically about it. I know that whatever he decides or she decides is always the right thing for the patient, for anything. So even we sound very philosophical, and I think it's a platform to talk about this. Anytime I go into a surgery, my first thing is to bow down my head and say, supreme power is somewhere else, supreme power is to you, and I'm just your humble worker. And that's my one thing which I never changed since my residency. But for me, I think there's an extreme responsibility which is provided in a hand,
Right.
to kind of do something right. And I think for me, that's like a godly complex. I don't know, maybe, I don't know, maybe I don't know how to put it the right way, but it's not superiority for me. It just means I'm going to do something right for the patient. And like TK said, I definitely encourage self-doubt, because self-doubt never makes me complacent. We twist and turn in the bed just before the surgery, which is a great thought, because I know what I want to improve. Then I know it makes me humble enough to ask people, hey, what should I do better, so that I can go from there. If I feel too comfortable with the surgery, I think there's always a chance for complacency. So I definitely value it. And I think over the years, maybe it gets better that we twist and turn less before the surgery, but I don't want it to come. I've slowly begun to enjoy that feeling of twisting and turning before the surgery.
In fact,
It's just my opinion. I think it makes me a better surgeon, makes me want to learn from other fields of surgery. We work extensively with ENT and plastics every day. It could be just another kind of suture which the plastic surgeon does it. And it's just great to learn from somebody. So I think there's a value to self-doubt, and there's a value to having imposter syndrome too.
No, I admire your self-doubt, and especially the thought of that you are the humble servant who's doing this. That's great. One of the best neurosurgeon in Seattle I used to work with, called Laligam Shekhar. I bring him up because his trainees used to go to Henry Marsh. He always prays with the patient, just saying that, no, I'm just rendering service. He prays with the patient that morning as he's consenting.
Nice.
In fact, Henry Marsh talks about a value of luck also in the same aspect, because so many times when difficult procedures go smoothly and without much, hiccups and complications, he doesn't take complete responsibility of the success on himself. That's where he even brings up the balance aspect. Taking too much of responsibility for success or failure somewhere takes away the arrogance of, and makes us more humble. Continuing the conversation, there's one aspect again which was discussed in this chapter, was the skills which we take so much of an effort to learn. They get rendered obsolete due to technological change. So many times, as senior surgeons, we're not very comfortable with that. Something that was like, for example, in cancer surgery, the microvascular surgery, and learning microvascular surgery through tedious process and so many years of training, and then suddenly you have a technology which takes over, and now you can instead of suturing, you can just staple. And the surgeon who has taken so much of effort to learn that and has derived a lot of let's say arrogance or confidence through the procedures that he or she was doing for all these years, suddenly becomes obsolete because of the help of technology. She doesn't really like it. What do you think? How do we see this scenario?
Yeah, so this is a very, very interesting thing, but I have a slightly different take than the way you frame this question. Personally, for me, something like that has not happened because the type of work I do, a lot of technology is not involved. Thank God for that. But I have been part of, I'll tell you a very classical example of the general surgeons. And I was in a very interesting period of time when I was doing my compulsory house surgery or internship in the surgical department in the late 90s. Till that time, in the place that I worked or studied, everybody did open laparotomies. They cut up, and you have the songs, cut it open and call the doctor and cut it open and remove the tumor and whatever. So it was always an open abdominal surgery. And that was a time when people were trying to learn laparoscopic surgery. Classical example of technology making, as you put it, your previous skills obsolete. But that is not true, because they were going into the same gallbladder or under the liver or whatever, all that anatomy that they had learned when they opened up, that had made them skillful in removing a gallbladder. That was the most common operation that laparoscopically they were trying to learn at that time. There was this guy who had done hundreds of open laparotomies and pulled out the gallbladder, now trying to look through a keyhole. He was a professor and he was doing it the first time, the second time. I've seen them do that. And all you have to do is to adopt to the new technology. And from where you start off, it is an advantage for you, whatever you have learned or used earlier. It's never going to be a disadvantage. Maybe what an example that I could give, because I'm not personally doing this, is, for example, doing endoscopic repair of a condylar fracture, for example. You have explored the condyle, you've opened it up, you know where these condylar fractures have gone when they're medially displaced. You've learned a trick or two how to reposition it. All of those is going to come handy even if you're using an endoscope and trying to, through a keyhole, fix that fracture. So I don't think the skills become obsolete at all. If you have learned how to do an impaction, you will then be able to do fix an angle fracture. And if you can do an angle fracture and impaction, doing a sagittal split osteotomy is that much easier than if you're going to be straight away learning a sagittal split osteotomy, not ever having removed hundreds of impacted wisdom teeth in that same anatomical area, or having fixed angle fractures. So I think technology, only problem is you have to keep up with the times. At the age of 50 years, you may have to go and learn how to look through a keyhole and move your fingers at the wrist rather at the elbow, etc. But these skills can be acquired. And whatever you had, some things may have to be unlearned. I'm sorry if I have been long-winded, but I hope I made my point.
Srini, what are your points? But before that, I'll just give you an anecdotal incident that happened very recently in the past conference, Kita, for which you were also present.
Yeah.
There was this paper presentation going on, and prize paper. Okay, so one of this young chap, he was talking about this latest technique of microvascular anastomosis, where staples were used instead of the sutures. Okay, so one of our senior guys who was sitting in the conference listening to the prize papers, when he heard that, and our chap, this young chap who was presenting the paper, he showed all that, and I could see that our senior chap was so upset that something, he said that how can you advocate such a technique on a platform like this, which is so easy to do and XYZ, whereas a microvascular anastomosis takes so much of time and so much of training and so much of hard work to reach that stage. It is not so easy to do microvascular anastomosis only with staples, and it can never be successful. And he totally negated the idea completely, and that poor young chap was left pretty embarrassed. And that was all for all of us to see. Yeah.
I think Srini is the good man to answer this. Was it Srini the man showing that new technique?
No, I don't remember that. And no, not at all. Technology has helped me immensely. It helps us on a daily basis. I look at my iPhone this morning, and as I'm talking to you, I'm looking at the 3 patients we have in the ICU, what dosages of pressure, norepinephrine is going into the patient who is sick. And technology tells me from this iPhone, what was his CT scan from last night. Yes, technology helps him for monitoring his body fluid input, output, and so monitoring. But does it make me a better doctor? It doesn't. So as Henry Marsh, as anybody says, biases, we all have our biases. Even whatever technology tells you, oh, this could be this, and we still go ahead and do whatever we need to do. And that bias can fairly complicate matters. That's the second aspect of it. Technology helps in daily life. Technology helps in helping us with our biases. But what is the most egregious part of use of technology is technology of, say, for instance, a harvested cell line or anything, or harvested amount of patient body fluid or patient biopsy, using it for research purposes without the patient ever knowing, and completely. All I need is one small iota of a cell line. That, again, egregious use of technology. But anyway, coming back to neurosurgical technology, amazing amount of technologies out there. You can perform the surgery 10 times before you walk into the operating room. You can see the tumor through the skull, where the tumor is, where your needle is going, by virtual augmented reality of the CT scans imposed onto the patient and other things. So the future is really bright. It is going to help us with all our, what you call, limitations, having the 3-dimensional view, having the 4th dimension. And say, for instance, on a routine basis, I ask Kita or all our, I see Shibani Das or Aarti Rao, other people, why don't you use an endoscope for a maxillary, odontogenic keratocyst? You will see around the corner. Or a condyle, every time you fix a condyle, it may not be endoscopic condyle reduction, but endoscopic assisted condyle reduction. So it will give you another dimension which you cannot see through your own eyes. The endoscope will give you a 4th or a deeper illuminated view for, so that is technology. So use technology and don't be shy of using technology in the most empathetic and self-awareness, as with informed consent, of course.
I think again we are coming back to the topic of balance. How to balance. Technology is certainly invading the medical field. We cannot stop that, and we have to hop on into this wagon. But at the same time, we have to know that technology is not going to replace the human part of empathy, as you said. The empathy part cannot be. Technology is not going to go and interact with the patient. You can't send a robot to talk to a patient and be there when the patient wakes up from the anesthesia. So
can I just add some more?
Yes, please.
So giving another example of how what you've learned is not an obsolete thing. I just remember this today. The fashion in orthodontic surgery is to do virtual surgical planning. But if you're sitting with your technician, your engineer, or whoever, and doing this virtual surgical planning, you've got to have done a number of, physical model surgical planning yourself. Otherwise, you are not going to get to know whether what he's doing is right. So, like Srini said, technology is going to make it more precise, so your outcomes could be better. It's not going to make your previous knowledge or your previous skills obsolete. That is what I differ with. I think technology is very, very useful. if you understand how to master that.
I think. Yes.
Can I cap it off? What Kita said
Sure.
is, for even the latest technology or a new idea, read an old book.
Yes.
True that. Yeah.
Okay.
There's a particular paragraph. We'll just quickly discuss this and then we'll move on. In this paragraph, Henry Marsh says that we have achieved most as surgeons when our patients recover completely and forget us completely. All patients are immensely grateful at first after successful surgery, but if the gratitude persists, it usually means that they have not been cured of the underlying problem and that they fear that they may need us in future. They feel that they must placate us as though we were angry birds or at least the agents of unpredictable fate. They bring presents, they send us cards, they call us heroes and sometimes gods. We have been most successful, however, when our patients return to their homes and get on with their lives and never need to see us again. And they're grateful, no doubt, but happy to put us and the horror of the illness behind them. How do you understand this? How do you agree this? What are your thoughts on this particular paragraph?
Yeah, so I want to disagree on what he's trying to say here. Again, it might be, as we discussed with Aarti earlier, a question of perspective of where you're coming from. So I think genuine gratitude could be seen many years after somebody's work has been done. I just give you an example of what happened to me a few days ago. There was this 7-year-old boy that had come. I treated him for a cleft lip and palate. This happened to be one of my better results. You might see his pictures in some presentations because I, like many others, don't show my failures, as you know, Taranjit, very well. So, but that is not the point. The point was this guy had become a talkative chap, which is for me a good thing because his speech was very clear. That is what I was looking for. And then at the end of this visit, the parents were egging him on to say something else. He was very talkative. He was conversing with me, all kinds of things, but he was not saying what they had wanted him to say, and they were egging him on. What did you forget to say to the doctor? And then he said, yeah, thank you very much for making me look so awesome. You know, it made my day. And this was many years after I had done the surgery. So it's the perspective in the types of cases that he was seeing. Maybe, you know, you have a tumor and you take it away and you get normal. You don't have to go back. But like Shivani will agree with me, that when you see these people again and again, I don't think they're worried, oh, will he not treat us better if we don't show that gratitude? That I think is a bit cynical. I'm a cynic myself, but this is a bit too cynical for me.
Srini, don't you think it has something to do with the culture of our culture, the doctor's culture, the patient's culture? Do you think culture is playing a role here?
Yeah, I mean, I agree with Kita, and I mean, 100%. You know, I agree. It's a culture. You know, it's self-importance. And recently with COVID, everybody suddenly, every hospital side, oh, welcome, this is where heroes work. No, we are not heroes in any set of the frame of mind. You know, we hardly any heroes. You know, half of our doctors are espousing wrong things. We've done so many bad things. I'm just doing my job. I signed up for this job knowing very well that I'm going to vaccinate, or I'm going to take care of sick people, or I'm going to take care of people who are in need. You know, I'm no hero. So this sudden God complex, sudden, you know, feeling of self-importance, I don't think it's perceived as a long-term good should be perceived as a long-term good for the profession. You know, I do not agree with Henry Marsh. And Henry Marsh, I come across on many occasions to be what you call as false modesty, as he says in multiple books himself. There is a false modesty about himself. And so he likes being pompous in some places. Yeah. So heroes we are not.
About that as well.
So
Taranjit, it so much reminds me of the saying where it is like, what's more dangerous, ignorance or illusion? I think the illusion of knowledge is more dangerous than ignorance. You know, it's such a great thought. just having an illusion that I know everything is so dangerous that, it's just something which came up to my mind when hearing you all talk about this. So I thought I'll share it.
We have some others. Dr. Yashaswini is also with us. She had something to say. Yash, would you like to unmute yourself? Are you still there?
Yeah, of course. I'm listening. I'm listening to everybody.
Something. Do you want to add to the conversation?
The thing that I texted about God complex is, I think it can kind of push you to becoming arrogant. So, it can creep in my opinion. And we were also discussing the question of, how often would you like to meet with your patients? And we're talking about the culture of the doctor. In my culture, I really like to follow up my patients, and they just drop in just to say hi, and it gives me a lot of feel good. I just like it when they do that, and I'm happy to see that they're fine without any problems, and I'd like to pick it at the earliest. So I think it's just a culture that you set up and the way you work, I guess.
I think a lot of this culture gets set up during our PG training time, the way we had seen our guides and our mentors doing it. Somehow
I differ from that. I beg to differ on that. These are not traits that I picked up from that time. I think these are traits that just crept into me as I, yeah.
In your own individuality.
Yes. Yeah.
That's wonderful too.
Yeah.
So, anybody else would like to add anything? Shivani, would you like to say something? Do you like to add?
I agree with what Krishna. I think I like to see my patients. I mean, it may not be something like a routine follow-up or something. If they come, just meet and say they're doing fine. It speaks good about what you do to them, and that they do remember us for whatever we have done. It goes beyond whatever you connect to your patient in a level beyond, their disease or their pathology. I think that's important, and it goes a long way on how you interact with them initially, and it helps in their recovery. I think, you're not treating the disease only, you're treating the person, you're psychologically trying to connect with the person, and I think that goes a long way. I also don't agree to what Marsh writes over here. It would become too mechanical how he puts it. You treat your patients and the patients forget you, or something like that. It's very mechanical. I don't connect to that. At the same way,
a bond, right?
No, I think what I kind of figured from what Henry Marsh was trying to say is, it's good when your patients are doing well and they don't come back to see you. It means it's a good sign that they're doing well, because in the initial phase, when they're kind of having doubts that some things may go wrong, they may want to keep the doctor, in a good relationship, so that what if I have to come back to you, then I hope you just remember me kinds. So many times it's like, if the patient is not coming back to you, we tend to assume, I would like to stress on this word, we tend to assume that all is well. It may not be so. It may be different, but we tend to assume so. And I think that is my perception of what Henry Marsh was trying to say when, it's good not to see your patients once they're done, because it just means that they're doing fine.
For all that, they may be seeking a second opinion.
We never know.
Yeah, so my surgery professor used to say, don't believe somebody who says I have no complication. Either is lying or they've gone to his competitor.
True. So true that. That's very true, sir. Yeah. There cannot be, you can't just be doing cases and say, I don't have any complications. That's so not true.
No, I like what Shivani also pointed out. There is a stage where patients may develop an emotional bond with you, because they love you as a person, and they connected with you, and they might just want to come back and meet you, and continue to, and through word of mouth, that is what. Through word of mouth, even send more patients because they find you so gratifying and such a good doctor. I think.
Yes, totally.
My uncle, my dad's brother, was the first MBBS doctor of his town. He passed out in 1924 and set up his practice. So he used to come home, I believe, with vegetables and fruits and nuts that the patients did.
Yes.
They'll bring, and they'll say, "This is from my garden." That is gratitude. This is after they're cured. So when you say that, they're worried that that strikes a wrong chord in me. That's not something that
I feel it has to do with the culture, because the Western culture does not allow people, there's a lot of boundary aspects, and they don't allow connection at a human level, particularly in a professional setup like this. I think it has of a cultural aspect.
That's I think Kita sir, that is a cultural difference I get, because I even I'm very happy to share that I come back with these little gifts from my patients.
It's so nice.
They bring me diaries. It's very cute, very nice. They just drop by to say, "Doctor, I just want to say hi." So it's very gratifying, and I keep in touch with all of them, and I make it a point to connect with the immediate family on a personal level, so that I know them by name and I know what relation they have. So I really try to do that. So like Shibani also said, for us, it's very nice. I really like to see them back and make sure that
there's one category of patients in maxillofacial area, which when they come back, they mean trouble, and that is temporomandibular joint disorders. I mean, we see them a lot, and we know that whenever they come back, the disease is back. I think Darpan is here with us. Is Darpan here? Darpan was there.
Yes, I am here. I'm very much here.
Darpan? Yeah, so Darpan is also doing he's doing great work in TMBs, and he is my next speaker for the next session on TMB. And Darpan, do you have any
When I was listening to the entire conversation, as in it is kind of the part of our training, and in most of the surgeons who are trained in appropriately as in a great surgical setup, I would not say even a great surgical setup, we tend, once the patient gets admitted, from the time of admission, you try and get connected to the patient. So every time you meet the patient before the surgery is connecting with the patient develops a bond with you. And then in my surgical training, we used to have ward rounds, then we used to have the lab check, and then we used to discuss with the patient, then we used to move the patient to OT. The morning hours, we used to be with the patient before patient enters to the OT operation room. Then in the post-op, in the recovery phase, we used to be present in front of the patient. That was the kind of training that we have been undergone. So we were with the patient throughout. We were like the family to the patient before the patient leaves the family outside the operating room. So that is how is the training. And I make sure in my practice today also that we connect with the patient before the surgery, on the operating table, before he goes to anesthesia, and in the post-operative recovery when the patient is off the anesthesia, and a regular post-op check is ingrained in us. So most of the surgeons, I think, who have that ingrained in them are doing well today. So that should be the training culture. I think that should be continued, which is, I think in the younger generations is losing down somewhere down the drain. I don't know why.
We are in a hurry. The younger generation is in a hurry.
maybe that.
No comments on that. Thank you so much for your comments, Dr. Darpan. We will have to move a little faster because we will again, otherwise we'll not be able to discuss some pertinent points. Now, when we come to this chapter 3, Hemangioblastoma, there was this important thing which I want to discuss, which is on cognitive distortions, various types of cognitive distortions, which as a surgeon we see, particularly anchoring bias and cognitive bias. Kita, would you like to highlight these? Where have you seen them, and in your practice, can you give some examples on these?
So let me start off with one of my own mistakes. You were probably my postgraduate, but you wouldn't have realized it, I bet. So yes, this is what they say, when you have a hammer in your hand, everything looks like a nail. That's basically what is a cognitive bias, and anchoring bias is a type of that. So I give you an example. So I got in a patient that had a radiolucent lesion in the maxilla, I think, yeah. And also she had small little radiolucent lesions in the mandible. That should have alerted me, but it did not. I was a young surgeon then, though some gray hairs had already come in. So I did a biopsy and it turned out to be a giant cell lesion. And I went ahead, got into this beautiful theater in Dharwad and went and chopped off.
I remember this brown tumor one, right?
Yeah,
Yeah.
you remember.
Yeah.
So already my mind had decided that this was a giant cell granuloma, and all I had to do was to go and cut it and keep her happily ever after. And it turned out to be a parathyroid adenoma, for which we had to go back and operate many months later because she came back with a growth again. So, you know, an elementary mistake, that one, I was qualified. I had an MBBS, an MDS, an FDS, RCS, whatever the alphabet soup that you could think of. I was qualified. I was a professor in the SDM Dental College, Dharwad, those days. But, you know, I made an elementary mistake. This is an example of that my mind at that point of time was just interested in doing surgeries, and it saw that as a central giant cell granuloma. So this can happen all the time. You know, you start doing, for example, this happened when distraction osteogenesis came into our lives. Once again, I was there ready at that time when McCarthy published the paper in 1992. And then we started doing distraction osteogenesis. I was into this game very, very early because an orthopedic professor of mine encouraged me to try it on the facial skeleton. He gave me some finger distractors, and I did some work on animals, etc. So I was there right from the day one, and then every case was a case for distraction at the turn of the century. You know, 20 years down the road, you look at whether all those indications have survived. Just have a look at it. You will find papers that were written in 2000, 2001 and 2. The indications were in pages. I'm not exaggerating. Small font, number 10 font, full page. These were the indications for distraction in the craniomaxillofacial skeleton. Today, you go and look at it 20 years down the road, what have stood the test of time, what have fallen by the wayside, you'll understand what a cognitive bias is. So it is telling you, I am the guy who is an expert in distraction. So whatever comes in is for distraction. One more example I'll give you from what Shibani will understand better than anybody else is these Pierre-Robin sequences. You know, in our hands, more than 95 or 98% of them just require a conservative management. I won't go into the details of that, but you will see papers that are written on hundreds of cases of newborn babies, infants who have had mandibular distraction because there were no criteria till recently as to who needed them. Yes, they had a small mandible, but why did they need that? That was not defined. Today it's happening. And in a few years down the road, you will find that there will be a more strict definition of when you will do a neonatal mandibular distraction. So this is a common problem that happens. Common problem that happens. I don't know how many of you are interested in cricket, but you know, if you are an expert in T20 cricket and you try to play the same way in a test match, you're going to be found out very soon. Yeah.
Srini, would you like to add something to this? Please tell us about your thoughts on cognitive bias and anchoring bias.
Srini doesn't have any bias. He's the most biasless person I've seen. That's how he lost all his hair.
So
he's human, right?
The truth is far.
He is
truth
human,
is far
of course.
from that.
Of course, he's human.
He
said he's not God.
Yeah. Then he has biases. Let's discuss how they come.
Okay.
Yeah.
So, self-check every day about biases. There are biases of different kinds. You know, Henry Marsh talks about entire bias. Learning of his biases comes from Thinking Fast and Slow,
Yes.
the Kahneman's textbook, right?
Yes.
So Other than Kahneman's, not textbook, I would say Kahneman's, who was a Nobel laureate, his book.
Yeah, seminal book
Yeah.
by Daniel Kahneman, yes.
Yeah, just because you have more knowledge doesn't make you more smarter. Just because you have more time to think about it doesn't make your decision way better. And, you know, as a human being, we think we remember way more than what we really think, which is hardly the truth. I mean, we don't remember a lot of things which we have forgotten. So such a bias. So anchoring bias, cognitive biases, and, you know, thinking of things like technology will add an added layer to, as Kita was saying earlier, added layer to your precision is also a bias. So there are a lot of biases we go through, and I'm just human being. So we need to, again, walk through the procedure, simulate a procedure, and perform a procedure at its appropriateness. And as history has taught us, you know, the wonderful surgeries are obsolete or not needed many a time, or not indicated most of the time. So I'll leave you with this thought again for everybody. You know, usually it is what do you call, the winner writes the right. Out of the distraction, the best distractors, wrote McCarthy or whatever, writes the best book. So think of the thousands of other people which we would have hurt in the way of trying to use this new technology, you know. So, I mean, I have a lot of biases. I try to check my biases every day. That's all I have. I mean, it's very humbling how much we do bad for a patient by all our biases.
Don't you think so that when it comes to, we talk about evidence-based medicine, evidence-based surgery, and probably we think that evidence-based surgery will bring objectivity to our decisions, and maybe it will help in eliminating our biases. But in fact, the kind of evidence that we choose to make our decision itself is based on our bias. For example, if I am doing, if I am good at nasolabial flap, which is the procedure which I am good at, I'm going to seek that evidence which favors my decision, which will allow me to do this procedure in every situation. So whatever procedure I wish to do, somewhere I'm going to look for evidence which supports my decision. Don't you think it works like that?
Thank
So
you.
how much can we talk about evidence-based surgery helping us to take a right decision for our patient?
Yeah, it's in today's word, it's called the echo chamber. You know, Taranjit, you surround yourself in the echo chamber, and the AI of these brilliant tech companies feed you more of that. So if you are an extreme right-wing Trumpist, as Srini is, he will only be getting news about Trump and this, you know, he's not going to get the leftist views, you know. That's an echo chamber. And so your mind truly believes that all the evidence that you're seeing is substantiating. So this is one of the problems with the artificial algorithms and artificial intelligence. It feeds you what you already know or what you're reading. Right, Srini?
I agree with you 100%. You know, you should be very careful of choosing your enemies and friends. So same thing, be very careful in choosing your technology, you know, and
Evidence and your evidence.
Yeah, evidence. So who wrote the evidence? For instance, I will tell you about vascular tumors. One of my wonderful mentor, you know, who does most vascular tumors, all the evidence comes from a couple of people who have done interferon therapy. Every new drug which came was used for treating vascular tumors. And in the process, you see so much of pain, so much of things for a non-neoplastic or non-malignant lesion, and injecting alcohol in it, injecting an interferon by killing the kidneys, the livers and other things. So as Kita said, you know, we are hurting people without, you know, reviewing the technology which is coming in, reviewing the outcomes of honest, without bias. Anyway, I'll stop there, but technology is your friend and foe at the same time.
About the anchoring bias, before we move on, I just want to give an anecdote from my own life. For example, if we have this schedule, my colleague, you know, my colleague or my intern would see a patient at the OPD chair, and they make a provisional diagnosis, and then they come to me that, madam, we have seen this patient and this is the provisional diagnosis. I already have a first-hand information in my mind now that this is the provisional diagnosis of this patient. Now, when I go and see, I'm going to search for what information she has already given me. And my mind already has some information, and it may actually be a contrary to the information that, my learned mind should have had. I should have seen something more, but I don't see because I have already been fed a certain information, and this anchoring bias is something that I have always experienced in my own practice. So whenever somebody feeds me an information about a patient, I try and stop them. That is another reason why I try and not look at the radiograph before the patient. Because when I see the radiograph or other investigations before the patient, I tend to miss out on some other things which are there in the oral cavity, which needs to be observed. And my whole focus is already on the radiograph, and I've already made up a decision what has to be done. Any comments on that?
But the problem is, Taranjit, nowadays, when the patient is referred to you as a tertiary referral care, they would have done a biopsy and they would have done an imaging and then sent it to you. But even then, it is up to you to among the clutter of all this. I have a famous thing which I always tell myself constantly in my mind. Among all this noise, there is a signal, and that's a signal I'm seeking, constantly. And, it's the path to nirvana sort of a thing. Every tumor patient is not the same. Every fracture is not the same. There is a component of something which I could be missing, and I'm seeking that missing point all the time. So that is signal in the noise.
Kita, you want to add something?
No, I think I'm talking too much.
In Zen, they talk about beginner's mind. I think that's what we need to have, a beginner's mind each time when you see a fresh patient, not to have any ideas, preconceived ideas or any other information which comes, and carry your experience with a fresh mind, a beginner's mind. That helps me to take care of a lot of my anchoring biases. From the audiences, whoever has anything to share, please unmute yourself and just be my guest. Absolutely no problem. Arjun.
Hello, ma'am. Yeah.
Would you like to add something? Hi, Arjun. Thank you for being with us.
Yeah. So, hi, everyone. Thank you. It was a great talk. Especially, I'm a big fan of surgeons when they get a little philosophical and they speak about other things than surgery. So this was a great. I just remembered one incident that. So one thing I would like to say is, like, there was a talk now about whether technology is our friend or foe. So one thing that kind of makes us keep technology on the friendlier side, what I understood, was to experiment a bit. So there's a saying that the more you sweat in practice, the less you bleed in war. So I just remember one instance during my fellowship in trauma. What we used to do is, as I remember one of the sirs saying that, if you want to do condylar reduction, if you're not good at endoscopy, you can do an assisted. So at least you get a view of how it looks. So what we used to do was, we used to do fixations of the fracture and then take a C-arm, the orthopedic C-arm, and then we would shoot and see how the skeleton looks after the fixation. It was a completely different view from the normal radiographs or the post-operative CT. So at one point, we did so much that we knew how to place the C-arm equipment and everything. And how it helped was, one fine day, we had a 3-year-old wheeled into the trauma unit, and she had a fracture, fallen down from the bike from her parents' lap. And she had swallowed a couple of teeth. So we're not sure whether the teeth were in the lungs or in the abdomen. And the gastroenterologist was waiting for us to tell him where it was. And of course, we took the chest x-rays. It was not there. What we did is, we wheeled in, because the patient was bleeding, we couldn't keep her down in the x-ray unit, brought her to the OT, did a quick C-arm. The technician was not available, but we were able to place the C-arm and do a quick evaluation, and we found it to be in the stomach. And then that kind of helped the thing. So why I'm telling you this is because when you kind of experiment with technology out of the box, one fine day you might find an application which might help someone. So that's kind of my outlook on that.
Taranjit, can I completely go? I've been forced to say something here. Can I say
please.
that?
Please,
Yeah, so
please. Yeah.
my-
You are
my-
a big fan of
my-
technology yourself. I'm sure you're going
Yeah,
to.
my 12-year-old son wants to inform you all that he has become my physiotherapist. Thank you.
Okay, wow. Thank you, Chirayu, for taking such good care of Kita. Okay, thank you, Arjun, for your views. I'm sure a lot of us agree with that, and it's pretty helpful. Yeah. Okay, can we proceed? So now we come to this 7th chapter called Meningioma, and in this, Henry discusses few important aspects of surgery. Like when patients ask pertinent questions, that would you do this procedure if it was your mother? Would you advise this procedure or do this procedure if it was for your mother, father, or family friend? Now, my question is, if in our Indian scenario, a lot of our patients are not so well aware. They have some kind of inferiority complex also when it comes to talking to doctors, and they say that doctors know the best. They would never ask any question to us. In that case, if patient is not asking this question as a doctor, would you ask this question in your mind for yourself that I am advising such and such a procedure for? Would I do the same for my own kith or kin?
Yeah, I think that's what it's supposed to be. It's not the patient or the parent asking you. It is you asking that question in your own mind when you are going to suggest a treatment protocol to your patient. It's you as a treating person who's going to think and say, will I do this for my mother? They don't have to ask that. It has to be self. There is no doubt about it. I heard this more than 30 years ago in my first week with a surgeon called as Leo Stassen. He's a great surgeon. He's I think retired now as professor in Dublin. And he told me this is what you need to ask yourself. Would you do this to your mother? Would you do this to your if the answer is yes, you go ahead and do it. So this is a principle that has been around for a long time, and we may not have to do it every time. If you are doing something very routine, very ordinary, but when you are doing something out of the ordinary, when you're looking at some alternatives, when you're thinking of out of the box, let us say, oh, I can do intra-arterial chemotherapy through, whatever.
Yeah, experimental.
So that's when this, I don't think it needs to come in every day. For example, going back to the same distraction osteogenesis, if you can just do a nice intraoral LIFO1 osteotomy and advance this maxilla and fix it and plate it and send the patient home, will you put in an extraoral device? When that kind of a situation comes in, you want to ask that question. And I think it's important, and I think all conscientious surgeons do it, but how frequently they do it, they may not face the occasion. If you're routinely every day taking out the tonsils, it might come one day, the question whether you would remove this tonsil for your child, but it will be less often asked than somebody who is, trying to innovate, trying to go out of the box, trying to take on challenges. He will have to answer these questions much more than somebody who treads the trodden paths. Yeah.
Very well said, Kita. Srini, what are your thoughts on this?
I think, yeah, every surgeon should think as you both say, and Henry Marsh says, whether I would do it on my child. But history has shown us multiple times, various times, even during a recent pandemic, during the World War II, the Nazi physicians and other people. Not everybody thinks this is not common. This is not very common. Majority of the people would even do it on their child, which is egregious. Many a time they would do it for their own countrymen. They would do it for their own, people all the time. Otherwise, we wouldn't have people who have deceived. There's a neurosurgeon who was in the US. There's a 3-series podcast if you ever want to show. There was a neurosurgeon with the highest complications in US, in Texas. He killed every patient on the way. He didn't know how to do it. Multiple levels of checks and balances did not work. And ultimately, he was barred from, imprisoned for not doing any neurosurgical procedures. So there are people who continue to do such procedures. And history has taught us, like even this COVID, I've seen the, on the leadership summit on the American College of Surgeons, the professor of surgery, Dr. Chintamani, came and professed online at one point saying that India has 30% vaccination when hardly 3% of vaccination had been completed. So this is a factual point. So people do things which are egregious all the time. And of course, we've been trained well, and we are fortunate for that.
Dr. Yashaswini wants to say something on this. Yash? I think this is part of Hippocrates' oath also.
Yeah,
right?
sorry.
Yeah.
I was finding it difficult to unmute myself. Okay. So we are talking about something like the daughter's test, isn't it? Would you ask this in your mind? So I have a small incident to share, my own. I was a fresh BDS pass out, and I was studying for entrance when my mom had very weird symptoms and all CNS signs and symptoms. I didn't know what was happening. As a BDS graduate in India, I had no idea what was happening. I was just happy to go through my entrance at that point and then just take her to hospital, and it was an emergency. And she was in a bad state. So she was slipping on every aspect. And finally, when I took her to the emergency, Manipal Hospital, Bangalore, she was listless. And then she had to undergo an MRI, and then, she was critical. So I have to thank Manipal Hospital at this point. I will never forget the emergency doctor there in the MICU. I still remember him so vividly. This is so many years ago. And within few minutes, she was under care, she was ventilated, and so all tests were being run. And since I was already having a medical background of some sorts, I gave all the history possible. And then in the middle of the night, Dr. Nair said, okay, we have run all the tests. She's normal to everything. There's only one thing left to do. I need to do an LP, lumbar puncture. So I need a consent. And he asked my dad. Now, my dad, being an advocate, he had no idea what was happening. So he said, no, Soumya, that's me. Molly, you take a call. So he was literally asking me to take a decision on this. And I was clueless. And so the doctor explained to me and all that. I said, please go ahead and stuff. And then the results came out around 1:30 in the morning. And Dr. Nair explained the results to me, which showed 98% lymphocytes, possibility of this. So for this particular moment, to save her life, I need to push in steroids. But in all probabilities, she could be having tubercular meningitis, which could also be detrimental to her. So I need to have your consent. And again, my dad is looking at me and saying, Molly, you make a choice. So I was caught in a situation wherein I didn't know what to do, because he's actually telling me that I need to give her steroids to save life. At the same time, it could also pull her down because, it's very suggestive. He said, I say highly suggestive of tubercular meningitis. Now, this is because, Taranjeet, you just said that, in our culture, we're not used to asking this. As a naive girl at that point, I don't know what came to my mind. I looked at Dr. Nair and I asked him, what would you do if this was your mother? I don't know what made me ask that. I just asked him because I didn't know how to make a decision. And I asked him, what would you do if she was your mother? He looked me in the eye. He didn't batter an eyelid. He looked me in the eye and he said, I would just go ahead with it. And I did not ask him a second question. I just signed the consent. I said, please do the needful, doctor. She's in your hands. So my mom came out of it. And she lived near normal for about a year and a half later until I lost her. But ever since that, I have no idea what made me ask that question. But I did. Because for me, at that point, that seemed to be the best thing to do. But thereafter, when we discuss this is a question I always ask myself. Is this needed? Will he do good without this? And this is a question I always ask myself. So I thought I should just share this at this point of time.
Thank you so much, Yash. It was so beautiful. Thank you for sharing your personal experience with us. Yeah. In fact, I have a similar one. I underwent a C-spine injury. I had C-spine injury. And then when I was going through the procedure, my whole my whole recovery period was more than 1 year. But when I had to be operated on a C-spine by a neurosurgeon, and he gave an option of conservative treatment versus surgical, my dad, who was very scared, he was horrified, he was not able to take the decision. He said that I don't want her to be operated, treat her conservatively. And I looked at my spine surgeon's eyes and I just asked him, sir, what would you do if it was your daughter? And he said, I would operate on my daughter. And we just left. My dad was still confused. And while going back in a taxi, because we decided that we are going ahead with conservative, I'll just wear a brace, that Philadelphia collar that we are supposed to wear. So I'll just wear the Philadelphia collar for another 6 months to wear in 8 months, and that will spoil my muscles completely and everything will be deteriorated. I wouldn't even know whether I'll recover completely. But then I told my dad in the car that I think doctor wanted us to get operated, and that was a better strategy. And thanks to the fact that my dad heard me, and we came back and I got operated, and I was appearing for my postgraduate exams within 6 months, and I took good care of my spine, and here I am. So yes, this is a very important question which patients should ask us in case if we have forgotten to ask ourselves.
I think it's important for the doctor to be honest as well.
Yes, I think it's very important for doctors to be very honest with patients when such a question comes to them. Yeah. Let's proceed further and move towards trying to wind up. The couple of important things, I think we will not be able to now share a lot of things because we don't have time, but there's something that we will still be able to talk. I want to discuss role of, in chapter 9, even though recognized complications happen during the surgery, Henry doubts himself and suggests that if he was in the right frame of mind, or what if the frame of mind was right, that this complication would not have happened. Now, I want to know from both of you, Kita and Srini, the right frame of mind. And when our frame of mind shifts, should we go to the surgical OR and operate? How do we deal with that? We may have personal crisis at home or something, and we may go to our hospital, and with that distorted frame of mind, we go to the hospital and we then operate. It has consequences. What do you have to say about that?
Yeah, in an ideal world, you would have the perfect disposition to do all your cases, but it does not happen. And I can tell you from my personal experiences, there are so many things that intrude into your state of mind at any given point of time. And you know some of the reasons that I have. So it's something that you have to live with. Definitely, if your mind is cluttered, if it is restless for a different reason, if it is not functioning at its full capacity, it is not going to take the right decisions, including your psychomotor skills can get affected. Having said that, do we then wait for this perfect disposition? No, we don't. You have to draw a line somewhere. Like, for example, all these things we can take cues from the airline industry. Today, simulation is becoming a big thing in medicine that is following the footsteps of the aviation industry. Similarly, the kind of working hours they have, the kind of conditions, they're quite strict about, at least the measurable things, that the crew cannot work more than, even if it's 5 minutes delayed, they will not continue with it. Even if it's going to be 10 minutes delay, by the time they reach the end of the journey, they will not start that leg of the journey. But these are the measurable things. But unfortunately, what you cannot measure, you don't measure. Even in the aviation industry, there was this infamous accident that happened at the Mangalore airport. I don't know whether you all know, it happened 20 years ago, where a flight from Dubai overshot the runway, and this guy was sleeping. The black box heard him snoring, the captain.
My God.
Right? Yeah. So why did that happen? It happened because certain things were not followed. So there has got to be a line, and that is for the individual to draw. But it's not possible to be in a perfect state of mind in your zone, as they call it, for every operation. That is not possible. So this also will depend on your conscience, and Srini might have a lot of stories about how people observe this in the breach rather than regularly. So yes, it is a problem. Agreed.
Srini, what are your thoughts on this?
So I'll vouch what Henry Marsh has said in a few other books or a few other instances about the airline industry. I remember that airline falling off the cliff and seeing that, Kita. So,
yeah.
So Henry Marsh talks about this on one of his videos about the Korean airlines, where because of hierarchy, the junior pilot would never question the senior pilot. So Koreans and so there was a instance where the Korean airline went down, and the junior pilot is telling the senior pilot 170, 50, 20, and then they crash. And so that's recorded by the black box again in the Pacific Island, coming to the Korean Airlines. So again, if there is no communication, if there is hierarchy, if there is other things, triggers which are impeding the communication flow and other things. So even doing the best of complication checklist does not work. I do a complication checklist. We stop the operating in the morning and we say, oh, where is the fire retardant or the fire extinguisher? But I'm always thinking, what if the fire retardant doesn't work that morning? And if you have an airway fire or whatever reason, so we don't question things. We do it mechanically without thinking, the checklist manifesto or whatever Henry Marsh is talking about. Coming back to the triggers. So there are 3 types of triggers I consciously think about. Say, I come with you to this lecture. I have 3 triggers. Internal triggers is what is happening inside me. I've not slept. I had a flight last night and I'm dosing with coffee right now. So the internal triggers is my tachycardia, my amount of need to go to the empty my bladder, and all these are internal triggers that your psychomotor skills, as you said, the glucose amount, the fine tremors, and other things are internal triggers. What are the external triggers? External triggers in an operating room, your assistant is a visitor or is a resident who is more adventurous in his operative skills, or he's a wonderful operator, and then the nurse on that shift is not there. So that's the external trigger. Then there is more than that. The triggers of, say, you have the worst scar tissue in a cleft patient. So internal, external, and this is the patient triggers, all 3. All 3 have to culminate in a proper synchrony for a perfect, smooth operation to happen. So I'll tell you one thing. One of my mentors, who was an ENT surgeon, would always tell in the fellowship, he said, Srini, keep the surgery boring. I don't want any surprises. So surgery boring meaning you repeat the same sequence of things, same checklist, same things you do repeatedly again and again. Then your triggers are minimized and the outcomes are the same.
Yeah. Can I relate another anecdote?
Please do.
So I was in Dr. Edenwala's OT. Edenwala was considered the father of Indian cleft surgery, a great gentleman, a wonderful surgeon. For those of you who don't know him, I was standing and talking to him, and they intubated this child, and the child arrested, and he then resuscitated the child. He did the CPR, and that was an esophageal intubation. They removed and re-intubated, and the child recovered, and we continued with the surgery. So while when he started the surgery, he was an 85-year-old man with hands as steady as a rock, but his hands were shaking that day. And I was a visitor, and he turned around to me and he said, Krishnamurti, this is not because I'm scared or something. It's just the adrenaline flow from that CPR I did. So, you always have to justify yourself, right? You have to keep telling yourself that you are in the best state of mind when you're doing your work, but sometimes you might be deceiving yourself. That's the problem. Yeah. And it can happen to anybody.
I also feel that emotions are contagious. I think he also mentions that in the book, and it is very, very important to. That is where I think the teamwork also becomes extremely, team compatibility between all the team members becomes extremely important. That there are no conflicting or hostile feelings towards each other, because the anger and lack of trust, these are the feelings which get transferred from your team members to you. And surgery being a team work, if we don't have that kind of understanding between our team members, then somewhere it's going to have an impact on our life, and somewhere in the
Taranjit, can I say something here?
Please.
This is where trust between colleagues and trust between a non-communication skill between, say, for Dr. Edenwala and Dr. Bonathaya would have come into play. Say, if somebody has just done a CPR, if we had another colleague said, hey, I'll take care of this, or can we postpone this patient for another time? Or, if you have to do it, I'll try do it. So that's when we build a good team, a good successor, rather than having a pyramidal system,
Yes.
Very important to trust a colleague to take over your surgery and do it for you. So, it should come from the least, what you call, important person in the room who could say and speak up and say, hey, we are not doing this right, and we could do it on another day. So
I think you're right. The hierarchy should be made more horizontal than vertical, and everybody in the team should be allowed to speak up their mind, and that can also help in eliminating a lot of errors, preventable harm that we are trying to discuss here, right? The causes of preventable harm. Now, is there anybody else who would like to add something to this? Because this is one of the most important aspects in the book that we had discussed. Other than that, let's come to the end point, and then we can wind up. This is another last paragraph that I would like to share and discuss with all of you. And please give me your views. Doctors need to be held accountable since power corrupts. There must be complaints, procedures, and litigation, commissions of inquiry, punishment, and compensation. At the same time, if you do not hide or deny any mistakes when things go wrong, and if your patients and their families know that you are distressed by whatever happened, you might, if you are lucky, receive the precious gift of forgiveness.
I agree with this 100%. There can be various circumstances. Most of the time, people are worried about accepting an error because they worry about the consequences, which he first spoke of. Litigation and compensation and court proceedings, etc. But the latter part of that paragraph is very pregnant. I think it as a long-term strategy, it works very well, but it's not so easy to do for most people. I just want you all to remember what happened a few days ago in a place called Dausa in Rajasthan. There was this lady who committed suicide. She was an obstetrician. One of her patients had died after having a severe postpartum hemorrhage, and then she and her husband, who not only treated her but who also owned the hospital, were booked under section 302 IPC, which is murder. And she thought, she got very disturbed as she wrote a suicide note and died, and it's created a huge amount of storm in our part of the world in the last few days. This is what happens eventually. I'm not judging anything here. I'm not judging whether the PPH could have been treated, whether this death was inevitable, whether it was prevented. We don't know a whole lot of facts here, but these are things that are happening day in and day out. Different circumstances in the US, different circumstances somewhere else, but the end results can be quite drastic. The simple reason here is that we, as a community of doctors, haven't understood that being frank, talking to your patients when things have gone wrong, probably admitting mistakes. If in this particular instance, I don't know anything, but I'm just telling you, that if you have the capacity to do that, it is possible. It's possible that the course of this kind of a flare-ups might minimize. I don't know how many of you were in this audience were there in the Bangalore meeting. We had a panel discussion on the last day, and I had a group of my mentors and mentees speaking in a session, and I asked my mentor, Professor Shyam Rao, or everybody to recount an incident that they remember, and he said this incident which throws a lot of light on what you have raised here. So he said that he operated on a child that was 1 year old for a craniosynostosis, and the patient died. And then after he had this chat with the parents told him, the parting words of the parent were that, doctor, please don't stop doing these procedures simply because this has happened. Let it not deter you.
Oh.
You know, you don't know what will come from which corner, you know. End of the day, I think the strategy that we have to follow, even if it looks short-sighted at first sight, might turn out to be a good long-term strategy. What I'm saying is that when you make a mistake, as we might often do, you have to learn a method of accepting it. I'm not saying you have to go and fall on the feet of the patients and cry, but there must be a method where you level up with them, and in more instances than not, I think things could turn out better. But the way things are happening now, at least, for example, in this country, is quite terrible. They'll go smash up the hospital, they'll burn the place, you know, they'll arrest you. And there is a huge amount of trust deficit. And this, I think, is happening because of this very important lack of communication, where all those other things we spoke about earlier, playing God, doing decisions that are for commercial considerations, and making a genuine error, but not able to reconcile to it. All these things, I think, are making things worse. But you never know what would happen if you adopt a strategy like this as a universal thing. We don't know. This will have to be an hypothesis at best.
Srini, what are your thoughts on this?
So yes, ethics is the biggest topic here, you know, in this particular thing. You know, earlier we discussed about we being heroes, and the hero, if you don't sacrifice, how can you even become a hero? You know, in our current training system, we think about, oh, work-life balance, I need to be off to see my thing. So you're not sacrificing anything on any reason, but at the same time, you want to be the same hero which in the war wounds, the physicians who treated, you know, were there. So that's one aspect of it, being hero. And just because you are a hero, you cannot commit mistakes. So the moment you become a hero and you cannot commit mistakes, that means you cannot ask for an apology or try to be, you know, ask for forgiveness. So being grounded, being humble, being in the know that you could commit a grave mistake which could affect another person is what will make you go to the patient's family and tell them, hey, I did this, and this may be the wrong thing I did, and I'm very sorry. And saying sorry may be legally not appreciated, but a genuine patient's family or a genuine patient's carer would understand what it is. Of course, there are financial implications and the societal implications. So what you want to talk about, but most people forgive you for whatever has been done. And you know, Taranjit and the rest of my audience, the best humbling feature you will get is you being mentioned in a patient's, a patient wrote in his final words for his eulogy after his death, what to be said in the church or wherever, your name is mentioned in that. And that is the most humbling thing you could think, that, you know, the best gift, or that you made your every bit of effort to work for that patient. You know, that's what you want to aim for. Mistakes happen, mistakes will continue to happen, but mistake should not be intentional. Like an honest mistake, as Henry Marsh says, is different from a intentional, arrogant mistake, or, trying to do something which you cannot do, or the hero complex of it. So humility, knowing that the mistakes happen, is the biggest thing we need to teach, biggest thing we need to carry up for ourselves on a day-to-day basis. That's all I have, Sharandi.
In fact, don't you think so that this part of the complication is the post-surgical part? As Shibani also mentioned, that if you have developed a good rapport with your patient right from the beginning, you can't just appear like a demigod at the end of the procedure when the mistake has happened and be honest and then expect it to be forgiven. And all the while, all that you had were trainees handling the patient and everything. If you were with your patient, and Darpan was also mentioning that, if you are with your patient right from the beginning and, are part of it, and throughout this whole process, you have developed a good rapport where patient starts trusting you, then patient knows that it's an honest mistake towards the end when it does happen. And we all know that mistakes happen. And then the forgiveness comes very naturally. It is not something that you even have to seek, as Dr. Krishnamurthy was saying, that his mentor did not even have to seek because he was genuinely, distraught because of what happened. And when you're genuinely distraught, you don't even have to seek the forgiveness. It's a gift of forgiveness, gift which is just given to you, even when you don't. Gift is something that's just given to you. You don't ask for it. That's why it is gift. And I think that's what he means. The rapport, I think moral of the story is that we as humans, if we don't have the God complex, if we have survived all that and we manage to live through realizing our own human fallacies, and then, Yash, do you want to add something to this?
Well, if I start talking, I'll have a lot to say, but I totally agree with whatever has been opined, and one has to be humble. And I think once we establish a good rapport, it is even easy for us to, we spoke initially regarding the informed consent. So what I do is, of course, I don't have as much as an illustrious number of years as Dr. Krishnamurthy and the rest, but sure. What I do is, when I have to decide and give them the treatment options and they take the options, I kind of walk them through every possibility, including paresthesia, including this, that, this. I walk them through every possibility. And this is something I saw Henry Marsh also quote in his book, that he does that in the OPD. So I walk them through everything. I give them time to think about it, and for them to be okay with what can happen. So, and then finally, when the surgery goes through and one of these things comes up, it could be just like a nerve paresthesia, or it could be a siloceal after condyle fracture, but they're already aware for it and they're mentally prepared for it. So they said, yes, doctor, you had already mentioned it. So that kind of makes things much more easy. And they're very accepting of it, because then things settle down. And there has been one time when I did mention everything about me not being able to reduce a condyle fracture. Now this is confession. And I had actually mentioned it, but I never thought it would happen. And it happened. In the theater, I did not have my regular assistant, and I was not able to reduce that fracture that day. And I tried and I tried so hard, because I wanted to do it for him. And I tried so hard. So much so that when I couldn't do it, I just broke down, because I was overwhelmed. And I was like, oh my God, why can't I do this today? It was just like a bad day for me that day. And I'm so grateful to my anesthesiologist and all the others in the theater. They could understand that I was really trying, and it was just not my day that day. And it was a difficult fracture that I was trying to do without my regular team. Okay, confession, you're recording it too, Taranjeet. So yeah. And what I did was, no, I don't mind, because after the surgery, I actually went up to the the bystanders, and I told them I gave it my all, but I'm sorry I wasn't able to reduce it. I mean, he had multiple fractures, of course, but this one I wasn't able to reduce it. And I had tears in my eyes when I was saying that, because I really meant every word of it. They were like, it's okay, doctor, you tried your best. But like you rightly said, they were very, I think they were very forgiving, because they really saw that I meant my sorry, and the sorry was not, and the next thing was I was paranoid. I shouldn't be giving him any deficits, and God has been kind. He had no deficits. So yeah, so that was some solace for me. Despite my trying so much, I didn't want him to give him enough deficits. He had none, and I was surprised. And oh my God, all those traction, nothing happened. But my being honest with them, and when they saw me being genuinely distraught, they were like, it's fine, doctor. You had already mentioned that it's fine. So yeah, I have some things to share like this.
Thank you. Thank you so much. Yeah.
Bunny, this is a confession session, don't you think, guys? All of you have been very clever. Now here I am confessing. Poor me. Kita sir, now this poor me is confessing everything. Poor me.
I confessed a number of times, but I think you decided to forgive me, so you don't remember it.
It's high time we confess. It's high time we confess. Because now we have entered patient safety movement. Yeah, and we are all working for the safety of our patients, because that's what present and future is all about.
Can I add one comment, final comment? Because of all these confessions,
yes,
and as Yashaswini was saying, the moment you record all these outcomes, which were not the ideal outcomes, it may not be the bad outcomes, and then work towards a goal of rectifying it. So it may help another trainee, another colleague somewhere, some patient ultimately,
yes,
whom we have the privilege of taking care of. So the more we record, the more we document, and the more we put our bad outcomes out there, I think we may learn, and we may, teach for the future generations to, as a stepping stone for their successes. And Henry Marsh says,
Henry Marsh has the whole chapter starts with mistakes of my life, right?
Yes,
begins
right.
with, one of the chapters begins with the fact that he discusses these mistakes very openly.
I have a confession to make also. For the last half an hour, I'm being threatened by my son. If I don't go now with him, he's going to throw me out.
For your sake, we are winding up.
Thank you. Thanks a lot, Taranjit.
Thank you so much, everyone. Thank you so
Bye-bye.
much for this evening. I hope you all enjoyed, and thank you so much for bearing with me and this idea of doing the review of this book. And I hope we all evolve as better surgeons after this. Thank you.
Thank you, guys. Bye-bye.
Yeah, lovely meeting you all. Yeah. Thank you. Thank you, Srini.
Oh, thank you, Taranjit. Appreciate it. It was wonderful. I mean, I love Arti's and Yash's wonderful instances. Your C-spine. Thank you. Nice meeting you all through this.
Yeah.
Nice meeting you too as well. And if you are readers and if you like reading, I'm just wondering if you have read this book by Sherwin Newland, the physician at Yale University. He has written 2 books, How We Die and How We Live. This was introduced to me by Gopal, and I read this very early. I think they're good books to read. I mean, so much was, it's more of a learning process of what we learn about how the disease takes toll in how we die. He in fact wrote How We Die first, and then he wrote How We Live. So I recommend these books to the younger graduates, but unfortunately, most of them do not have the habit of reading at all nowadays, because it helps them understand physiology very well. He has explained it through patient cases and what actually happens and how we live. So that's normal physiology, and how we die is the pathology, and with the human connect. So if anytime you like to read, if you have the habit of reading, then yeah.
Do share with this group. Yeah, just you had a question. Dr. Srini is still here with us. Do you want to ask him? I'm sorry, I saw your question pretty late. Yeah, just
Right.
So
okay.
Thank you.
Okay.
Thank you.
Yes,
Yeah.
I'll
Thank you.
certainly look out for that book.
Yeah.
And the best book,
Sherwin Newland.
best book, Sherwin. Yeah, I will look out
I'm
for
just
that.
calling you Srini. Sorry, I don't
That's
even
fine.
know you.
I mean, I have no such. I told you, as Kita knows, I have no such pretensions. Don't worry, you can call me.
Yeah.
Nice. Thank you.
Thank you.
We're all students. Okay. Bye. Tarun.
Bye. Have a good weekend. Bye-bye.
Bye.